A little bit of a sound, but the sound is not needed. It's more the video. The bottle is yours. This one.
Good morning. It's 7:30 and it's time to start our Pediatric Grand Rounds. So welcome everybody. Just a quick reminder, this is a month of April is the Child Abuse Prevention Month, and therefore we have two presentations. Last week, Dr. Kusun gave a wonderful presentation, and today Dr. Reyes-Ruiz will be giving his presentation. This presentation has been approved by the Texas Medical Board for continuing medical education in medical ethics. And even last week's presentation was approved. So those of you who signed up last week will automatically get credit for ethics in medical education. With that, I'm going to hand over to Dr. Kusun, who is going to introduce this morning's Grand Round speaker.
Thank you so much. Good morning, everybody. And again, thank you for giving us the opportunity to talk to you during April Child Abuse Prevention Month. So today I have the great pleasure of introducing Dr. Daniel Reyes-Ruiz. He is our second-year fellow here at in our training program. He went to medical school at San Juan Bautista School of Medicine in Puerto Rico and completed his residency at the University Pediatric Hospital, and then moving here to San Antonio. He is interested in prevention of child maltreatment and in physical abuse, including burns, bruises, and abusive head trauma. He has done a really great job during his fellowship in getting involved in educating the community and implementing child abuse prevention strategies. Today, his talk is going to be within the scope of his fellowship project.
So, good morning to everyone. Thank you for being here this morning. So as Dr. Kisun mentioned, my name is Daniel Reyes-Ruiz. I'm one of the Child Abuse Fellows. This is my fellow project. As co-investigators, I have my mentor is Dr. Nancy Kellogg, and I also got some collaboration from one of the UT pediatric, the graduating pediatric resident, Dr. Katlyn Correa, and also we got some help from one of our statisticians, Dr. Wouter Koek. So today I'll be talking about a topic that comes up frequently in our clinical practice, and specifically, what should we do when infants and children present with skull fractures? Do we need to be concerned about abuse, and how should we get a skeletal survey to assess these infants? So I have no financial or other disclosures to make. So the objectives today are to enhance understanding of how skull fractures occur in infants and young children. It's also to determine factors that predict whether infants and children with skull fractures get skeletal surveys. And also we're going to describe clinical features in children presenting with skull fractures that are associated with concerns for abuse. So as a short background, so skull fractures occur in up to 20% of children less than 2 years old who present with blunt impact trauma to the head. Up to one in 3 skull fractures are caused by abuse, and currently the recommendations for evaluating children 2 years and younger for suspected physical abuse includes obtaining a skeletal survey. So the importance of obtaining a skeletal survey is that it can help us identify additional injuries that may support the diagnosis of abuse, even in the absence of external signs or external physical findings. So based on the recommendations from the American Academy, or the American College of Radiology, the Society for Pediatric Radiology, a skeletal survey consists of at least 21 radiographs and sometimes more when we need oblique views of the bones of the extremities when it's needed to see some more subtle fractures. So the clinician's decision about skeletal surveys. So in general, clinicians are highly variable in their decisions whether or not to get a skeletal survey. Sometimes infants present with scalp swelling and no explanation. And in these cases, it's especially important to determine whether the infant is mobile and capable of, for example, falling off an elevated surface like a bed or a couch. And also, clinicians may consider the characteristics of the skull fracture, like if the fracture is complex and if there are multiple skull fractures. Finally, physician experience and training, for example, the expertise or the training between pediatric emergency medicine or pediatric trauma or surgery, they all may have different approach in deciding whether to get a skeletal survey or not. So why are skull fractures important? So the AAP defines abusive head trauma as an injury to the skull or intracranial contents of an infant or a young child's head, and it's due to inflicted blunt trauma or impact, or it can also be violent shaking. So skull fractures may be a sign of abuse, which would require a skeletal survey, and in some instances also a head CT. So those are some of the questions that that some clinicians might encounter. So here are also some clinical questions about skull fractures. First, skull fractures are relatively common in infants due to a number of factors. These factors like growth and development, and we will need that information in order to interpret mechanisms of a fall. So then there are questions about the amount of force needed to cause a skull fracture and whether a caregiver should know when an infant falls and get a skull fractures based on the infant's cry or any symptoms of pain. So also skull fractures are sometimes associated with extraaxial hemorrhage. So do we need to worry about when there's a skull fracture and an extraaxial and an underlying extraaxial hemorrhage? And also if there are certain features of the skull fracture that should prompt or should increase the concern to do an abuse workup. And finally, how likely is that a clinician will miss abuse if he doesn't do the workup, if he or she doesn't do the workup for abuse, which includes a skeletal survey. So what causes skull fractures? So it's not surprising that skull fractures are among the most common fractures in children less than 2 years old, and more specifically in infants younger than 12 months. So the typical history that we usually get with these cases is that the infant, the caregivers noted that the infant had a scalp swelling and that they rolled or crawled or scoot off the bed. So due to their development and their weight distribution, the most common injury will be a skull fracture because the head impacts the ground first, and because also their parachute reflex is not fully developed by that time. So infants are also more prone to fractures because their skulls are very thin and very pliable, and less protected because of the open fontanelle. So this slide shows how the infant skull increases in thickness by sixfold over the first 3 years of life. So other clinical questions about skull fractures are whether they can occur with very short falls, and whether an infant could get a skull fracture without the caregiver hearing or seeing it, even though they are in close proximity. So the video that this video that I'm going to show you now appears to confirm these possibilities. This video is an actual footage from daycare, and the history from this child is that the parent noted a swelling to the infant's head. They took him to his PCP, and he was diagnosed with a skull fracture. So the parent brought it to the daycare, and the daycare reviewed the video footage from the day before, and then they saw what happened. So when the child was sitting in the playing mat, now in the daycare, and you can see that the caregiver is in the room just a few feet away. So let me show you now here the videos. Watch the little girl that's sitting on the playing mat. This girl specifically here. Okay. Then she flips up back. Okay. So note that the child fell backwards. She did not cry out. And after that, she resumed her activity after falling into the edge of the wooden shelf. So this was a focal impact that hit that back part of her head, and that caused a skull fracture. The caregiver was in close proximity, and they didn't notice what happened. So what about the risk of intracranial hemorrhage in children and infants with skull fractures? So given the potential that the infants have thinner skulls, there is also greater potential to injure underlying blood vessels. So one of the reasons skull fractures can be concerning is that the potential for extraaxial hemorrhage. So the dura underlying the skull is highly vascular, as you can see here on this fluorescent stain. And so there is potential to injure those small blood vessels and cause a focal small subdural hemorrhage. As you can see here on this head CT, there's a very, very small subdural underlying this fracture. So this extraaxial hemorrhage tend to be very small and tend to resolve without treatment, whereas if they're small, whereas if there's large extraaxial hemorrhage, then they may not resolve on their own. So in asymptomatic children presenting with a primary injury of a skull fracture, this extraaxial hemorrhage do occur, but tend to not progress and not require treatment. So are there certain skull fractures? Are there certain features of skull fractures in infants that can be that are more concerning for abusive trauma? So complex and multiple fractures have been associated with abuse in some previous studies. Many studies have documented that there's a higher rate of abuse diagnosis in infants, particularly in those under 6 months of age. And then also a more recent study indicated that complex fractures are uncommon and can result from both accidental trauma and abuse. This last research paper also found that all of this information should be interpreted also in the context of history, so obtaining a good history and also doing a very thorough physical exam. Here we can see a type of fracture. So we have a simple linear fracture here, a depressed skull fracture. Also, we have here what's called a multiple skull fracture. We can see 2 skull fractures here. And then we also here can see complex or branching type skull fractures. So, how likely is that I'll miss abuse if I don't get the skeletal survey? So this is the last question, but this is the last one of the last questions that a clinician is: how likely am I to miss it if I don't send a skeletal survey? So there's a recent study by Dominguez from 2022 that looked at this question partially, and specifically in children younger than 12 months. And they found a low rate of abuse, but some of their infants diagnosed with abuse had symptoms, in difference from our paper. Many of these children had normal skeletal surveys, and very few presented for another assessment or concern for abuse before their third birthday. But a key question remains unanswered is: how often do we need to get a skeletal survey in children and infants under 2 years old who are asymptomatic, so they don't have any symptoms, any vomiting, any neurologic symptoms, and who have skull fractures? And if there are any features in the clinical presentation that can assist us in making this decision. So our first aim is to whether or not the skeletal survey is likely to reveal other fractures, and the second aim would be how often the skeletal survey impacts the decision or the diagnosis of abuse. So our inclusion and exclusion criteria. So in our study, we focused specifically on children under 2 years old that were asymptomatic and were assessed by a child abuse pediatrician, excluding all children with any symptoms or previous head injury or any surgery. So why are child abuse pediatricians consulted for infants with skull fractures? So at Christus Children's and University Hospital, from the two hospitals that we obtained the data, this is the clinical pathway that guides clinicians to first identify a child at risk. So there's a long list of criteria for the criteria so that they should call the child abuse team. But then there's these two items here that specifically refer to infants and children that may present with skull fracture. So any fracture in a child with an inconsistent or unexplained mechanism, or any unexplained skull fracture or intracranial injury in a child less than 5 years of age. So clinicians may then assess the child further to determine if there's a concern for abuse, or they may consult the child abuse team for further to determine whether there is a concern or whether workup is needed. So sometimes what happens is that clinicians proceed with the abuse workup before calling us. Others call before and ask for recommendations before or during the imaging studies and the lab tests. So let's start with the method. So we did a chart review of over 300 patients and determined who did or who did not get a skeletal survey, and abstracted several variables from this patient. So we got age, gender, race and ethnicity, the development of the child, also type and number of skull fractures, if there was a history of impact or not, the results of the skeletal survey, and the assessment by the child abuse team. So part one, who gets a skeletal survey? So our first goal was to compare children with a primary injury, a skull fracture, who did not get the skeletal survey to those who did get a skeletal survey. So specifically, we wanted to determine whether all of these factors, so history, age, type and number of skull fractures, if that predicted a clinician's decision to obtain a skeletal survey. So most of our patients were males, Hispanic, younger than 6 months, and most of them had single, simple, linear non-depressed skull fractures. And overall, our rate of abuse after all of the assessment was low. About 9% of all the children that were uh, assessed were diagnosed as concerning for abuse, and 15% of them were diagnosed with concern for neglectful supervision. Um, so, so what factors did not impact the likelihood of getting a skeletal survey? So age, race, gender, and ethnicity, fracture characteristics, specifically if they were single or multiple, simple versus complex, or depressed or non-depressed, that did not affect the decision to obtain a skeletal survey. Also, the presence of an extra-axial hemorrhage did not impact the likelihood of getting a skeletal survey. So this might be surprising, but most of the extra-axial hemorrhage in these cases were small and usually directly under the fracture site. And all of these children were asymptomatic. But many of them with this extra-axial hemorrhage were hospitalized overnight for observation and presumably to ensure that this subdural or suprarachnoid hemorrhage did not expand and and it wouldn't cause any more severe symptoms if symptoms started to show. So we're going to talk about a couple of cases during the presentation. This is the first one. So this is a 6-month-old who was with mother. They were in the grocery store, and the 6-month-old was sitting strapped on a shopping cart. And then a 4-year-old brother was also inside the cart. So mother turned to one side to reach for baby wipes on one of the shelves. And the 4-year-old that was inside the cart also leaned over to a nearby shelf to reach for a toy. So because of his weight, that caused the cart to tip over. So the 6-month-old fell and hit the floor, hit the right side of his head, impacting the right side of his head and his whole body. So there was no loss of consciousness or vomiting after the incident, but mom noted that there was like a soft, boggy spot on the head of the baby and brought the baby in. So a head CT showed that the baby had a non-displaced parietal fracture that we can see here, and underlying the fracture, we can see a very, very small extra-axial hemorrhage. So the reason why I'm showing this case is because we have a 6-month-old with a skull fracture and an extra-axial hemorrhage, but a skeletal survey the child abuse team did not recommend a skeletal survey because the fracture and the small extra-axial hemorrhage underlying the fracture can be explained by the fall from the shopping cart. So what factors did impact the likelihood of getting a skeletal survey? So children with skull fractures evaluated at Christus Children's were more likely to have skeletal surveys than children evaluated at University Hospital. Also, patients without a history of impact were more likely to get a skeletal survey when compared to patients with a history of impact. So all patients that clinicians had a concern for abuse had a skeletal survey, and the concern for abuse impacted the decision of obtaining a skeletal survey. So infant assessed as concerning for physical abuse were more likely than those who were not diagnosed with physical abuse to have a skeletal survey. And so this is what's supposed to happen. This reflects the child abuse team recommendations and the guidelines that a skeletal survey is needed for all children under 2 years of age who are suspected victims of physical abuse. So this is part 2. Part 2B is the skeletal survey matters if it adds information to the diagnosis of abuse. So in this part, we look at children who did get a skeletal survey to determine what factors predicted the detection of non-cranial fractures. So each of these factors in the second part was closely approximated in frequency to those seen in the total sample, except for the last two variables, which are the concern for abuse and the concern for neglect. This makes sense because we would expect to have more skeletal surveys for patients in whom there was a concern for maltreatment. So we can see that most of the patients who had a skeletal survey were male, were Hispanic, and younger than 6 months. Most of them had a history of impact, and most of the skull fractures were simple, linear, single, and non-depressed. So what variables did not predict non-cranial fractures on a skeletal survey? So patients 6 months and younger were as likely as patients older than 6 months to have non-cranial fractures. The skeletal survey. Males were also as likely as females to have non-cranial fractures on the skeletal survey. And also race. So this indicates that all of these variables are not a predictor of obtaining non-cranial fractures on a head CT. So what variables did predict non-cranial fractures on a skeletal survey? So patients evaluated at Christus Children's, as I mentioned before, also were more likely to have non-cranial fractures compared to children evaluated at University Hospital. Also, having a complex fracture was associated with a positive finding or finding a non-cranial fracture on the skeletal survey. So those are the variables that predicted finding non-cranial fractures on a skeletal survey. So part 3, how was abuse diagnosed in children presenting with skull fractures? So the child abuse team, out of those 170 patients who were assessed with a skeletal survey, the child abuse team assessed 27 patients as concerning for abuse. Children presenting with multiple skull fracture or non-cranial fractures were more likely to be diagnosed with abuse by the child abuse team. So how was abuse diagnosed in children with negative skeletal survey? So no positive findings on the skeletal survey, but they were diagnosed with abuse. So in these 27 patients that were diagnosed or that were diagnosed with a concern for physical abuse, age, gender, race, and ethnicity were similar to the overall study population. But of note, all of these 27 patients, 17 had negative skeletal surveys. So this 17 patients, the abuse concern was based, most of them, 10 out of 17 patients, because of the inconsistent history, that the history provided by the caregivers did not match the mechanism for the injury or the development of the child. Also, there was diagnosis of abuse based on cutaneous injuries, so bruises, most of them, and also in 3 out of the 17 cases there was a confession by a caregiver. So basically, the majority of these cases, 17 out of the 27 patients, were diagnosed based on history and the physical exam, which is information that we should generally gather before ordering a skeletal survey. So did the skeletal survey make any difference in the diagnosis of abuse? So out of the 170 patients who got a skeletal survey, 10 had non-cranial fractures that contributed to the concern for abuse. So out of these 10 patients, 5 of them had classic metaphyseal lesions, which are fractures that are highly specific for physical abuse. 4 out of 10 patients had acute or healing rib fractures, which are also highly specific for physical abuse. And one out of these 10 patients had an acute femur fracture, and no history was given to explain the injury. So here we can see our second case. This case is about a 2-month-old who presented to the ED with caregivers also for a soft or squishy spot on her head. So caregivers reported that they noticed the soft spot on the child's head that same day that they brought him to the ED. Caregivers denied any history of falls or trauma, but reported that the child was under the care of other caregivers during the previous days. So based on all of this information, the history, the physical exam, a skeletal survey, and also head CT was done. And it showed a depressed right parietal skull fracture. So a head CT was done first to check because of the squishy spot. So then because of the fracture, then a skeletal survey was also done, and there was a classic metaphyseal fracture on the right distal femur. We can see it, that fracture is right here on this corner. So this is a very specific fracture, and it's very concerning. It's concerning for physical abuse. So in this case, it was a skull fracture, and the skeletal survey added some additional information about a fracture that is highly concerning for physical abuse. So we also had some patients that had non-cranial fractures on the skeletal survey, but the child abuse team assessed the child as not concerning for physical abuse. So why was that? So there were 3 patients that were found with this characteristic. So the first one is a 3-month-old with a history of being dropped by father. Father was carrying her, and father dropped her, and the baby fell to the floor and hit the left side of her head and her body. So a skeletal survey was done in that case, and it showed a skull fracture and also a acute left clavicle fracture. So in this case, even though the child has an additional or a non-cranial fracture on a skeletal survey, both fractures are adequately explained by the fall from father's arm. So the second case was a 9-month-old. She had a skull fracture, but also was found to have a healing avulsion fracture on the left thumb. So in that case, caregivers reported that a previous instance a couple of weeks earlier where a door closed on the child's finger, and that's what caused the fracture. So here we have a history for the additional fracture found on the skeletal survey. And then there was another case of a 1-month-old that fell from mother's arms while being fed during the night. Mom fell asleep, and the baby fell from her arms. And in this case, also the skeletal survey showed a skull fracture and also a acute clavicle fracture. So also in this case, the both fractures could be or can be explained by the history provided by the caregivers. So the diagnosis was or non-specific or low concern for abuse. So study implications. So did the skeletal survey matter? So out of 13 children with non-cranial fracture, non-required treatment, 10 had fractures that supported the diagnosis of abuse. 1 had a fracture that supported the diagnosis of neglect. That was the child with the avulsion finger of the thumb. So, and then 2 were assessed as non-specific for abuse or neglect. So age, gender, and race. So age, gender, and race did not predict getting a skeletal survey or diagnosing abuse. And while this was a very select population of infants and children with skull fracture, this finding specifically is in contrast with previous study that it shows that previous study has showed that there's an increased likelihood of abuse workup and diagnosis of abuse among minority children. And also, there are other studies that have reported that abuse is more common in infants less than 6 months old, compared with infants between 6 months of age and 24 months of age. So this was a slight difference from previous studies in our study. So why were the consulting hospitals different? So these findings, because we got the data or from Christus Children's or from University Hospital. So these findings may represent differences in clinician discipline. Also, this differences in pediatric radiology expertise, adherence to the clinical pathways I showed earlier, or also, even though we're in the same city, different patient populations. It also may be that some clinicians prefer guidance before they order a skeletal survey and other test, and others feel more comfortable and prefer obtaining the test before consulting on the diagnosis, consulting the child abuse team. So do fracture characteristics help with the decision to obtain a skeletal survey or for the diagnosis of abuse? So in most cases, complex and multiple skull fractures were identified on skeletal survey, and it did not impact the decision to get a skeletal survey. So specifically, depressed skull fractures might probably affect the decision to obtain a head CT, but more in the surgical part because children could have intracranial hemorrhage due to the depressed part of the fracture. But a complete abuse workup, including a skeletal survey, should be done specifically for children with complex or multiple skull fracture based on the data that we obtained during this study. So extraaxial hemorrhage. So for the most part, all of these extraaxial hemorrhage were either subdural, subarachnoid, or epidural. They were small and they were underlying the fracture site. So while many children were hospitalized overnight to monitor for neurologic symptoms, this hemorrhage did not expand and children did not develop any neurologic symptoms. And not all children in this study underwent a head CT. So in the majority of the cases, the decision to order a skeletal survey was done before obtaining a head CT. So did the skeletal survey matter for the abuse, for the diagnosis of abuse? So this study found that the lack of history or history of no impact influenced the decision to obtain a skeletal survey, but did not predict the finding of non-cranial fractures or being diagnosed with abuse. Because as I mentioned earlier, out of the 27 patients, 17 were based on history, which includes inconsistent history or it's not adequate for the development of the child. Also, caregiver confession, which can be obtained during the part of history taking, and also a good physical exam or cutaneous findings. So these results or our results emphasize the importance of obtaining a good complete history that includes a developmental history and also a thorough physical exam. So some takeaway points. So our results suggest that most children under 2 years old who present with a simple single fracture, a consistent history, consistent based on the development of the child and the injury, and no concerning cutaneous findings on the physical exam, these children may not need a skeletal survey. But the key part here is that a detailed history and a consultation with a child abuse pediatrician can help in obtaining what information should be obtained from the history, and examination of for any cutaneous injury is very important in these cases. So some of our limitations, the study was that it was a retrospective design. The data was collected from existing records. We had no controls over potential co-founders. The sample size was small. The number of patients with additional fracture was relatively small, 13 total cases. This might have affected statistical power. There's also potential for documentation bias. So some findings, specifically history of impact or the history that's documented on the chart, may relies on documentations from the medical records and the providers, which may not always be complete or completely or accurate. And also there was limited follow-up. So since children with skull fractures and low or no concerns for abuse did not get a follow-up skeletal survey, there is a potential that there was some missed non-cranial abuse-specific fractures that we couldn't see because a follow-up skeletal survey was not done. So here are my references. And any questions?
Thank you, Dr. Reyes-Ruiz, for that wonderful presentation on skeletal survey. There is a question in the chat box from Dr. Lipset. Would you ever recommend an abbreviated skeletal survey that includes long bones and chest?
I'm sorry, can you repeat the question again?
Would you ever recommend an abbreviated skeletal survey that is long bones and chest, not the 21 views, but just limited to long bones and chest in children with skull injury, I guess?
So yesterday I was in a lecture and I noticed also that some clinicians order specific parts of the skeletal survey, not the complete skeletal survey, but that's specifically in infants that don't have any fractures in the initial skeletal survey. If our protocol here at Center for Americans and what I've learned is that always order a complete skeletal survey every time.
Okay. Any other questions, comments?
What do you recommend if you're in an outlying area and you don't have a child abuse specialist to call?
What I would recommend in these cases is so the key part here is a good history. Specifically, so when we go and get this history, we get as much detail as possible from what happened from the incident. We ask parents to actually reenact what was happening. Where were they sitting? Where was the kid placed? Or where did they go? Like a very, very specific history. And as think about if what they are specifically saying matches with the development and the type of injury that the child has. And also the physical exam is really important in these cases. So I would rely on the history and the physical exam.
Hi, Dr. Kissoon. Sorry, I'm here with Dr. Reyes-Ruiz. If you are here in South Texas, you can call us. Even though we don't have access to medical records in this area, San Antonio and much of South Texas, you can call us and we can help you in, talking through things, what kinds of things you need for history and things like that. And we're available 24/7 on our on-call phone.
Thank you. There's another question in the chat box from Dr. Rizvi. Have you seen humerus fracture with venipuncture in a 1-year-old?
Have I seen fractures? I'm sorry, I can't hear you well.
Have you seen a humerus fracture with a venipuncture when they draw the blood in a 1-year-old?
With a venipuncture, no, that shouldn't happen with a normal blood draw. A humerus fracture should not occur with normal handling of a blood draw. No. Dr.
Rizvi, you may be asking for a specific reason. Can you speak up and say why you're asking this question?
Yeah, can you hear me?
Yes, we can hear you. Yeah.
Okay. The reason was that because there was no history, because this is a small kid sent for the blood draw and eventually developed the hematoma. And when the X-ray was done, we found out there was a fracture there, humerus fracture. There was no history of fall, nothing like that. So skeletal survey was done, it was negative. So it was hard to see, whether it's, in my experience of like 30 years practice, I've not seen one. So I was wondering, how much, the red flag should be raised in these cases.
So,
Thank you.
Yeah, so a normal, typical blood draw from a child shouldn't cause a humerus fracture. So that, for us, that would be highly concerning for abuse, and we would get additional history, talk to the parents, and do the whole investigation. And in that case, if there's concern also, it was a 1-year-old, if I heard correctly. So so in that case, it will be the whole workup. Yes.
Okay. Thank you.
And and that will include a so if in that case, doctor, if you didn't see anything on a skeletal survey, we would recommend also a follow-up skeletal survey in 10 to 14 days after to look if there was any missing, if there was any fracture in the first skeletal survey that we didn't see, and then we see some healing in the follow-up skeletal survey.
Okay, thank you.
Thank you. Any other questions, comments for Dr. Reyes? Dr. Lucifer liked your presentation. He says, great presentation.
Yes, I saw it. Thank you, Dr. Lucifer.
Any other questions, comments? Okay, thank you. Thank you, Dr. Reyes-Ruiz, for that wonderful presentation. Thank you all for attending this morning's Grand Rounds. We're going to conclude. We'll see you next week, next Friday. Now, next 5 presentations will be given by our graduating fellows. So all 5 graduating fellows will be presenting every Friday till the first week of June. So please do attend and encourage them for their presentation. I will see you now in about 10 minutes at the faculty meeting. Thank you.
Thank you for having me. Good day.
Thank you.